Hello and welcome on behalf of Meridian Valley Lab to the webinar on Adrenal and Thyroid Synergy. I hope you all had a wonderful Thanksgiving holiday. Today's webinar will be presented by Dr. Michael Kaplan, one of the consulting physicians here at Meridian Valley Lab. Dr. Kaplan graduated from Bastyr University in 2005 and is a board-certified naturopathic physician. Dr. Kaplan operated a successful practice in Seattle focusing on chronic inflammatory and autoimmune disease. He now brings his expertise in functional medicine to Meridian Valley Lab, where he consults with other physicians on the safe and effective use of bioidentical hormones. Please feel free to ask questions through the webinar, and Dr. Kaplan will answer them either during or after the webinar. Your participation is strongly encouraged. Also, you may want to refer to your metabolism chart, which may have been emailed to you. Now I'd like to turn over the webinar to Dr. Kaplan.
Welcome, everyone, and thank you for joining us. It's really a pleasure for me to be with you today. Looking at the names of our attendees, I see some familiar names, and thank you very much for being with us. Well, let's go ahead and get started then. So we begin with a question. Are the adrenals and the thyroid really completely isolated systems? Well, if you're joining us today, then I'm sure you all have at least an inkling that the relationship between the two is more than just tangential. And in fact, there is a long-standing philosophy and history that does recognize a synergy between these two systems. Today we're going to delve into the science that underpins this approach. So by way of introduction, let's take a look at a brief review of systems. And as you can see, the differences between hypoadrenalism and hypothyroidism can be slight. Both can present with fatigue, depression, poor concentration, or other mental complaints, digestive complaints, dry skin, low body temperature at times, muscle pain, and also menstrual irregularities. However, let's dive in a little bit deeper and examine some of the nuances that might be able to help us differentiate clinically between the two. So in a patient with hypothyroidism, we have a characteristic low and consistent body temperature. However, in hypoadrenalism, the temperature can be low but fluctuating. The energy pattern in both tends toward fatigue, but in hypothyroidism, the pattern is stereotypically a little bit more consistent. In hypoadrenalism, the pattern is more quote-unquote wired and tired. In hypothyroidism, people have difficulty losing body fat, whereas in hypoadrenalism, they may have difficulty gaining muscle mass. These people may be underweight overall. Blood pressure could be normal to high in hypothyroidism and normal to low in hypoadrenalism. We have a characteristic high normal or high total cholesterol in hypothyroidism, and we can also have low cholesterol in hypoadrenalism. This is always an interesting pattern whenever low cholesterol presents itself. On physical exam, hypothyroid patients can have a reddish appearance to their face, and hypoadrenalism, perhaps some pallor. The secretions, the sweat in hypothyroidism can be fairly scanty and can be fairly profuse in hypoadrenalism, and both can have IBS. The hypothyroid picture is more commonly constipated. The hypoadrenal picture is more variable. However, the hypothyroid patient can have diarrhea as well, and this may be due to a relative dysbiosis or imbalance in gut flora related to the slowed transit time, the decreased peristalsis. So in a moment we're going to dive into some laboratory assessment possibilities for working up hypothyroidism and hypoadrenalism. But first, I just threw up here this metabolism chart our famous metabolism of select steroids, and we're going to come back to this a little bit later. Today, of course, we're focusing on the glucocorticoids and the mineralocorticoids, and of course, an androgen, DHEA. All of the above, of course, are steroid hormones and come from the adrenal gland. Now, we have a few laboratory methodologies. We have blood, which of course excels for rapid measurement of TSH, free thyroid hormones, thyroid antibodies, reverse T3, and DHEA. It's also convenient as it is quick, and it's conducive to frequent follow-ups. Saliva does a great job with cortisol and can be useful at times to map out a diurnal salivary cortisol curve. And then in the urine, we have a simultaneous ability to measure multiple hormone systems, in this case cortisol, cortisone, and their respective metabolites, as well as free thyroid hormones and DHEA sulfate. Of course, the other benefit to the urine methodology is a full 24-hour perspective that we get that really does a good job of smoothing out the peaks and valleys involved in the pulsatile secretion of these hormones. So here's an overview of our most comprehensive urine panel. It's called the Comprehensive Plus Hormone Profile with HGH. This is page 2 of the profile, and there's a lot of information here. Again, we're going to focus on just a few areas today: the DHEA, the glucocorticoids and their metabolites, and the mineralocorticoids. On page 3, again, just a brief overview. We'll focus in on the free thyroid hormones. There's a lot of other information here that's available to you. Many of you are already familiar with our 24-hour urine profiles. So today we're going to take a little bit more of a concise view of this comprehensive report. So let's dive in now to the adrenal-thyroid interaction. We have a couple of interesting phenomena from case reports, and really this group of observations, this group of phenomena was really what in part inspired me to present this webinar today. We have across 4 decades case reports that describe patients who are both hypoadrenal and hypothyroid, and when these patients are treated with thyroid hormone replacement, they don't tolerate it very well. They at times will present with what's known as an adrenal crisis. This is an acute condition that sharply contrasts with Addison's disease, which is a chronic, insidious condition. The second phenomenon is that these same patients oftentimes experience a reversible hypothyroidism when the adrenals are subsequently treated. A little bit later in the webinar, we're going to address what might be going on here, why is this happening, and what we can do about it clinically. Here's just an abridged list, half a dozen or so, of case studies written up in the medical journals that talk about this very phenomenon. Very interesting. So you'll notice if you have time, if you have the inclination to delve into these case reports, that the patients in question typically have full-blown Addison's disease. And Addison's disease, while rare, is a somewhat useful model to study because it's a very pronounced form of adrenal insufficiency. But the problem clinically for you and me is that Addison's disease requires a 90% destruction of the gland before the diagnosis can be made. So while it's a useful model to study in the literature, we shouldn't wait for the development of full-blown Addison's disease we should act earlier when the adrenal hypofunction or the adrenal insufficiency is subclinical. So again, short of Addison's disease, you may have already found a handful of patients who are clinically hypothyroid, but for whatever reason may not be able to tolerate even small doses of thyroid hormone replacement. And by small doses, I'm talking about a quarter grain of USP thyroid or 25 micrograms of L-thyroxine. These patients may be hypoadrenal at the same time. Okay, let's dive into some of the science, some of the mechanisms that links the adrenal and thyroid glands. And I organized some of the research here into 3 levels of analysis. There are certainly more levels of analysis. This is somewhat of an arbitrary construct, but I think useful to organize the information. So first we'll talk about altered receptor hormone interactions. Then we'll talk about inflammatory consequences, and lastly, altered peripheral conversion dynamics. Okay, let's get right into it. And by the way, from here forward, whenever we're talking about a mechanism, I'm going to have a summary table at the bottom of each slide that basically sums up what I'm talking about in words above. And so this way, you can at a glance know what I'm talking about, because some of the dynamics get a little bit complicated. I've done my best to simplify them for the purposes of our discussion today. So firstly, in a low cortisol state, there's research that shows that the sensitivity of the T3 receptors for binding with the T3 hormone was decreased by an average of 50%. Very, very interesting. The body becomes less sensitive to thyroid hormone with low cortisol. Now, low cortisol also has another consequence. It can increase the TSH, but at the same time decrease the thyroid's ability to respond to the TSH. So it strikes me that this is yet another reason to perhaps rely less on TSH as a sole marker for thyroid health, especially since, as we'll see, low adrenal function and low thyroid often will present together. By the way, the reverse is true. When cortisol is high, TSH goes down. And the literature proposes a mechanism for this interaction. The mediator is a hormone from the hypothalamus called somatostatin. And of course, more research is necessary, but it's been proposed that the influence of high or low cortisol may be more important than TRH from the hypothalamus in controlling TSH. And that's definitely not what we all learned in school. Okay, we just got done talking about some effects of high or low cortisol on the thyroid gland. Let's shift our focus for a moment to the adrenal gland itself. So in the context of low thyroid hormone, animal models found a lower glandular weight, specifically for the adrenals, and also an increase in ACTH, but similar to what we saw a moment ago, a decrease in the ability for the adrenal gland to respond to the ACTH. So there's something about this imbalance, this low thyroid environment that dulls the adrenal gland to its primary stimulator, ACTH. More and more, it's looking like a healthy adrenal gland relies on a healthy thyroid. Okay, now let's move on and look at some consequences of inflammation in the body, and what patient of ours does not have some inflammation to a certain degree. Well, tumor necrosis factor alpha, or TNF-alpha, seems to act on the pituitary to block the stimulation of ACTH by hypothalamic CRH. And there are some other pituitary hormones that are inhibited as well by tumor necrosis factor alpha: growth hormone, luteinizing hormone, and prolactin. So again, inflammation makes the pituitary less able to respond. Now here's another inflammatory consequence. TNF-α, interferon gamma, and especially interleukin-1 beta inhibit the 5' deiodinase enzymes that are very important for peripheral conversion from T4 to T3. Now, speaking of peripheral conversion, just by way of review, it's important to keep in mind that the thyroid produces only 20% of the circulating T3, and of course, this is the active hormone. The remaining 80% of the circulating T3 is formed external to the thyroid in the peripheral tissues, primarily the liver, although there are other tissues involved, such as the kidney. And so, keeping in mind factors that influence the peripheral conversion are really of critical importance clinically as well as academically. Okay, now this brings us to one of the more startling discoveries that I made in preparing for this webinar today. Turns out that there are a number of reports that describe a low cortisol environment increasing the peripheral conversion of T4 to T3. And this really runs counterintuitive. Low cortisol or hypoadrenalism, increased peripheral conversion, in other words, more active thyroid hormone. What could be going on here? Well, it's actually not altogether clear why this happens. It may be an adaptive response, and a little bit later on we're going to take a look at some of these mechanisms all together. But wouldn't it be interesting if we could see this dynamic in play in another environment? Well, it just so happens that we have that. We have a couple of population groups with known HPA axis dysregulation and dysfunction: combat veterans and sexual abuse victims. These population groups have suffered and have well-documented adrenal insufficiency, and turns out that there's a body of research in the psychiatry journals that has taken a look at these population groups and has found an elevation in free T3, beginning with soldiers, specifically with combat-related PTSD, without an elevation in free T4. And they found this relative elevation, and I'll get to what I mean by relative in a moment, amongst different societies: U.S. Vietnam veterans, Israeli combat veterans, and also Croatian veterans. Now, taking this to the next level, the researchers also took a look at present-day World War II veterans. We're talking about elderly men who fought in World War II, and found the very same phenomenon: a relative elevation in T3 but not T4. And this is surprising for a number of reasons, but not the least of which being that thyroid hormones tend to decline in aging, not elevate. Also, these gentlemen were never diagnosed as hyperthyroid because the T3 was never outside the normal reference range. So back to our phenomenon where a clinically hypothyroid patient, and these patients may very well have been clinically hypothyroid because of everything else going on, despite the relative high normal T3, these same patients may very well be amongst the group that would not be able to tolerate even those small doses of thyroid hormone replacement. I bet if these patients had their adrenal glands treated in a functional manner, they would improve. And of course, we also saw a very similar dynamic amongst women who suffered childhood sexual abuse. Very interesting. I wonder, just as an aside, if the functional medicine community is aware of this. Certainly the psychiatry community is. Okay, so now let's consider the inverse for a moment. We talked about low cortisol, increased peripheral conversion. Now, high cortisol and decreased peripheral conversion, this was found at pharmacologic doses of a corticosteroid and also physiologic doses. And I think this is really important because people in a stage 1 or alarm phase, if you will, from Dr. Hans Selye, who are experiencing the high cortisol phase of the stress response may present with a short-term relative hypothyroidism, and would be important to take into account their adrenal health before jumping in and treating the thyroid. So it's important to keep in mind other factors that influence peripheral conversion dynamics. Deficiencies in certain nutrients like selenium, zinc, and iron. Selenium, of course, very important because it's a cofactor in the deiodinase enzyme complexes. Advanced age, as I mentioned a moment ago, tends to decrease peripheral conversion, and this was not seen with those PTSD combat veterans or the women who suffered the sexual abuse. Type 1 diabetes decreases peripheral conversion, and it's theorized that it's because of the liver's involvement in type 1 diabetes that the peripheral conversion is somewhat downregulated. Of course, chronic liver disease for the same reason, and certain drugs, especially beta blockers, many patients may come into our offices already on beta blockers, and this will affect their thyroid health. Need to keep that in mind. Now, what about autoimmunity? We certainly cannot separate out an autoimmune dynamic whenever we're talking about hypothyroidism. And indeed, Addison's disease is usually an autoimmune dynamic. And so within the autoimmune sphere, we have a syndrome called type 2 polyglandular autoimmune. And while rare, it turns out that the combination of autoimmune hypothyroidism and autoimmune hypoadrenalism go together, and this combination is the most common polyglandular autoimmune combination. So we've been talking about these two hormone systems for a while now outside of an autoimmune context. Turns out they go together even inside an autoimmune context. And also, it's important to keep in mind that autoantibodies manifest years before clinical symptoms, and so if a patient has autoantibodies, it's very important to pay attention to that, even if they are euthyroid or otherwise relatively asymptomatic. Now, treating the underlying causes of autoimmunity is a little bit outside the bounds of our presentation today. However, I would be remiss if I didn't mention a couple of dynamics that really seem to rise to the level of importance. Celiac disease and gluten sensitivity are highly associated with autoimmune thyroiditis, whether it be the polyglandular type, meaning combined with another endocrine involvement or otherwise. So very important to rule out gluten sensitivity in these patients. Also, very interesting group of studies here, and I've referenced one of them, that shows that selenium, again, important for peripheral conversion, has the ability at relatively modest doses to decrease anti-thyroid antibodies, specifically anti-TPO. And the dosage that was studied here was 200 micrograms a day. Interesting to note that they did not find this effect at less than 200 micrograms a day, and also when the selenium was removed from the patient's treatment regimen, the anti-thyroid antibodies did return. So it's important to continue to address underlying features even with the treatment of selenium as effective as it seems to be. And then also, with regard to IBS, we talked about IBS in our review of systems earlier. Both hypothyroidism and hypoadrenalism can impact the digestive tract. And so with patients who have IBS that seems to be relatively refractory to treatment, may be a good idea to take a look into the endocrine system. Okay, now let's take a moment and put it all together. I have here a table that summarizes all of the mechanisms that we talked about to this point, and this is primarily for your quick reference in the office if somebody wants to know what impacts what. This is kind of a quick reference guide. And of course, the clinical consideration that really does underpin all of these mechanisms is the need to support the health of the thyroid and the adrenals concurrently. Now, while I think this table works, it's somewhat linear and doesn't perhaps take into account the true interrelationship between all of these dynamics. So here, let's organize the information a little bit differently. We have the effects of low cortisol, we have the effects of the inflammatory cytokines, and we have the effects of low thyroid hormone. And we can see that by these overlapping circles here with the dotted lines, that there is an interaction, that all of these dynamics may be happening simultaneously. Certainly there may be more than one or more than a few happening concurrently, in turn creating a whole milieu of dysfunction. So the bottom line really here is that these mechanisms may be happening at the same time, creating kind of a mishmash of clinical symptoms that are going to manifest as hypothyroid and hypoadrenal. And again, not to sound too repetitive, but we need to treat both together. Now, let's look at a case study. We have here a 72-year-old female, Margie, who is 5'6", 155 pounds. She presents to the clinic with fatigue, and a quick review of systems revealed some pertinent information. She has cold body temperature, she has aches and pains, sleep disturbance, alternating diarrhea and constipation. As a matter of fact, she was previously diagnosed by another doctor with IBS. But really that was not her chief complaint today. The chief complaint was just being tired. Physical exam was somewhat unremarkable except for a mildly elevated blood pressure. So our plan for workup is going to involve a CBC with Chem panel, a thyroid serum panel with autoantibodies and reverse T3, and we're also going to run a 24-hour urine hormone panel. Okay, let's take a look at the 24-hour urine hormone panel first. We have here page 2 of our Comprehensive Plus panel, and there's a lot of information here that, again, is beyond the bounds of our presentation today. I'm going to focus in on the DHEA, circled at the top, the cortisone, which is the storage form of the glucocorticoid, cortisol, the active form of the hormone, some mineralocorticoids, some cortisol and cortisone metabolites, which we get in the urine. And what we do with these metabolites is we add them together, and you see here I've done that, and specifically I'm talking about the THE, 5-alpha THF, and THF in the parentheses, and this gives us a sense of 24-hour glucocorticoid output. And in this case, the total 4774 is a little bit suboptimal. We'd like to see this total at least 5,000 for female. At the very bottom of the page, we have 3 line items that are mineralocorticoids. And while technically related to aldosterone, we use these mineralocorticoids as a secondary check on adrenal health, and specifically glucocorticoid health. And we find that in general, when these mineralocorticoids are either low in the range or frankly low, we have a chronic nature to the adrenal fatigue. Now hold that thought. In this particular patient, she's not looking that bad at all. DHEA is in the lower end of the range, but certainly could be adequate in general for a 72-year-old. Cortisone, frankly, looks fine. Cortisol is suboptimal at 64. We'd like to see that a little bit closer to 90 or 100. And I mentioned that the cortisol-cortisone metabolites at 4774 was a little suboptimal as well. So the amount of adrenal decline is fairly mild in this patient. Back to the mineralocorticoids, I'd like to take a moment and just explain why we use them as this secondary means of analysis. So back to our metabolism of select steroids chart, we have here on the left side the glucocorticoids, cortisol, cortisone, and their respective metabolites. And then all the way to the left we have aldosterone and mineralocorticoids. So in a chronic adrenal fatigue in which there's a lower amount of mineralocorticoids, what's going on here is a phenomenon that you might call a progesterone steal. Because if you recall, there's a progesterone backbone that goes into glucocorticoids as shown by this chart. And when the adrenals are under a physiologic stress of any kind that goes on for a long period of time and goes chronic, the body preferentially shunts the progesterone-based backbone to glucocorticoids, and the mineralocorticoids get the short end of the stick, so to speak. So again, that's why we look at the mineralocorticoids as a secondary check on the chronicity or the long-term duration, perhaps, of the adrenal fatigue. Also on our 24-hour urine hormone profile, at the comprehensive plus level, we get urinary-free thyroid hormones and urinary-free T3 and T4, both low in the range. Urinary-free T3 is an exceptionally sensitive test, and we're going to compare this in a moment to some serum results. TSH was a little bit elevated, as you can see. Free T4 was in the normal range. Free T3 was low at 1.2, but not dramatically so. A reverse T3 is high in the range at 20.5. Antithyroid peroxidase, however, is elevated. Certainly, I'm sure we've all seen much, much higher levels of this antibody, but again, we're going to pay attention to this because antibodies do go up prior to more dramatic disease presentation. And then anti-TBG was in this case normal. On our CBC with Chem panel, the primary findings here were an elevation in triglycerides and total cholesterol. Okay, so our treatment plan in this case has been cobbled together from pertinent research studies, clinical experience here at the Tahoma Clinic, and some of the presentations that Tahoma Clinic physicians, particularly our medical director, Dr. Wright, has given over the years. What's notable about at the outset of this treatment plan is we're not going to give this patient any thyroid hormone right now. We're going to support adrenal health with nutrients and one hormone, DHEA, and we're going to see how she responds from there. Worth noting, though, that this patient declined any estrogen or progesterone-based analysis. She just wasn't interested in the bioidentical hormones, so we restricted our level of treatment to the adrenals and the thyroid. So this page will be emailed to you later, as will the rest of these slides for your reference. Now, I'd like to highlight a few of these that are, I think, especially noteworthy. One of them is magnesium. There was a, and by the way, thank you so much for your questions. I'll take them at the end of the presentation. I found it useful to be reminded that magnesium can be useful in treating hypoadrenalism, and certainly 200 to 600 milligrams, that's what was studied. It's a relatively mild dose. The limiting factor in some patients may be bowel tolerance. There was a study that showed decreased adrenal hormone output with a magnesium deficiency. And then also, there's a body of research that shows that DHEA, again, as an adrenal hormone, may play a very important role in an adrenal treatment plan. And in this case, transmucosal pertains to delivering the DHEA in the form of a cream, but not applied to the dermis, applied to a mucosal surface, in this case, the mucosal surface of the labia majora. And we do this because we find exceptionally good absorption in that tissue area, and also we find relatively small amount, if any, receptor fatigue. It permits somewhat lower doses and more effective biologic response. And also, by way of preview, my colleague, Dr. Pushpa Larson, will be presenting a webinar on DHEA sometime early next year. So stay tuned for more information about that. Notably, we're going to go ahead and follow up right away with a food allergy panel for this patient and a stool IgA gluten sensitivity screen, as both of these may be going on in the background. Okay, so our immediate follow-up, we get our fecal anti-gliadin IgA back in a couple of weeks, and we find a fairly elevated score here, 120 units. The reference range is 0 to 10. Very useful to test for anti-gliadin IgA antibodies in the stool, I believe, because that's the compartment that IgA is made, for one, and number two, can detect earlier reactions that precede the generation of IgG. And that's why we ran the test separately from the food allergy panel. But we went ahead and did the food allergy panel because there may be other problematic foods that need to be temporarily removed from the diet. So adding to the treatment plan, dietary counseling to avoid these indicated allergens. And by the way, I don't ever mean to suggest that dietary and lifestyle modifications should ever come secondary or as an afterthought. But in this case, the patient was very interested in seeing the objective evidence, literally in black and white on the paper, before she would proceed to making any dietary changes. And so that's why we held off with this particular part of the treatment plan but upon seeing the results, she was able to muster her motivation to make some dietary changes. In the case of the wheat and the gliadin, that's going to have to be a more permanent change for this patient. In the case of the dairy and the soy, that may be a more temporary change, depending upon how well gastrointestinal healing can take place and whether or not a rotation diet is conducive to her lifestyle. Okay, so at 6-month follow-up, we have back our 24-hour urine hormone profile. We see a dramatic improvement in DHEA. Of course, we expect that. She's taking DHEA. And we're going to focus here on the areas that I've circled. Cortisone has also improved. It was around 120 before, and now it's improved to 175. Cortisol, though, remarkably has improved. It's now at 108. It was in the 60s before. The cortisol-cortisone metabolites add up to 6,031. They're now in the ideal range between 5,000 and 7,000. So overall, a pretty nice improvement in her overall adrenal health. Now, she wasn't all that imbalanced before, but remember, we're treating the person, not the laboratory. And her clinical presentation of fatigue was severe enough to be important to her, and clearly we have some hormonal improvements to show and substantiate her clinical improvement. Now, at the bottom of the page, we have again our mineralocorticoids. All 3 numbers have improved. They weren't very terribly low before, but now we can see that with an increased ability to cope with physiologic stress, the body is able to divert a little bit more of that progesterone-based backbone back over to mineralocorticoids because the demands placed upon that raw material by the adrenal gland is somewhat lessened. Okay, and now again, back to the urinary thyroid measurements. Both have improved dramatically. They were both below the reference range before, and there still may be a little bit room for improvement. However, given the fact that she's 72 years old, I think this is a fairly nice improvement for her. Now let's take a look at her serology. TSH improved as well. It was in the mid-2s. It's now 1.8. Free T4 was normal before. It's still normal, but a little bit perhaps higher. Free T3 was low before. It's now a little bit more solidly mid-range. Reverse T3 was in the top of the reference range before. It's still in the higher section of the reference range. There may yet need to be some additional follow-up on this. There is some evidence clinically that reverse T3 can be related to heavy metal toxicity. That may be the subject of another presentation down the road. The antithyroid peroxidase was still positive, but it's gone down, which is a positive sign. And we would expect, with the continued dietary and lifestyle modifications, that this number would continue to improve. Also, we've seen improvements in triglycerides and total cholesterol. Very nice. In conclusion, as I mentioned a couple of times here, we really need to consider adrenal and thyroid systems as a symphony operating and impacting each other. And, of course, the take-home message from today is to consider treating the adrenals and thyroid concurrently when indicated. Now, just a minute, not done yet, not so fast. There are some areas for further study. There are some unanswered questions here. What are the consequences of cortisol imbalances on reverse T3? The answer to that is unknown at this time. What about the consequences of cortisol imbalances on so-called acquired thyroid hormone resistance? This is really a very new area of research. Many of you may have seen a relative degree of thyroid hormone resistance in your practice. We still need to find out more about this. Personally, I'd like to know the mechanism by which cortisol dulls the thyroid, and also the mechanism by which low cortisol increases peripheral conversion. And of course, there may be others. Bottom line here is that because these answers are not apparent, we have to dig for them, we have to find them. Okay. This concludes our webinar. I want to thank you so much for participating today. Please go online to meridianvalleylab.com and register for next month's webinar on our brand new blood viscosity profile, which will be presented by our very own Dr. Holsworth on December 14th at 11 a.m. Pacific Standard Time. We're very excited about the launch of this new profile and are proud to be the only clinical lab in North America to use this state-of-the-art technology. So if you have any questions, I would be more than happy to take them at this time. Okay, just give a few moments here, perhaps, for people to type in. While that may be happening, I want to just give you a little bit of a preview. If you have time to please stick around. We're going to be showing right now a short 5-minute video on blood viscosity that will give you a sense of the importance of our new profile, which again will be the topic of our next webinar. So I do invite you to stay around for the next 5 minutes. It's really a very impressive display. Okay, with that, thank you so much for your kind attention today. It's really been a pleasure assembling this presentation for you. And without further ado, here comes our blood viscosity video. Pardon me, technical difficulties, just one moment.
Sorry about that. We had some technical difficulties. We'll be replaying it.
When a healthy infant enters the world, his heart pumps more efficiently than it ever will throughout his lifetime. His arteries are soft and flexible. His blood pressure is low. His blood is thin and flows easily. The effects of time, lifestyle, and the environment have not yet begun to take their toll. Like water flowing in a gentle brook, an infant's blood streams smoothly and with little effort through his arteries with each heartbeat. The arteries expand and easily absorb the contractile force of the heart, which keeps the blood moving forward in a laminar flow. But time is not kind to the arterial system. As the years pass, the child grows taller. His blood pressure must rise to produce the larger, erect body of an adult. As he eats animal fats and is exposed to environmental stresses, his blood gets thicker. As a result, his heart must work ever harder. Like a steam heating system, the circulatory system is a closed system. The arteries must absorb all of the stress from the laboring heart. A vicious cycle begins. As the heart works harder, arteries in certain regions of the system are overstretched, almost to the point of rupture. The most vulnerable arteries are those located near the heart. Acting as shock absorbers, the proximal aorta and the arteries feeding the heart and brain absorb the impact of ejected blood as it is punched into the arterial system by the now forcefully contracting left ventricle. These arteries begin to be stretched to their limits. Arteries in the lower extremities also become overstretched, but for a different reason. The pull of gravity on the blood in the legs of a person standing upright adds to the already increased pressure in the arterial system. To protect themselves from further stretching and possible rupture, the arteries in these vulnerable regions begin to thicken, stiffen, and harden. In other words, they adapt. As the arteries get tougher, they become less compliant, drastically changing how the blood flows through these regions. To continue to maintain life-sustaining perfusion, blood flow becomes turbulent. Turbulent flow sets the stage for the initiating event that causes atherosclerosis. With turbulent flow, eddies form at the arterial bifurcations, changing direction with each contraction of the heart. The back and forth flow of the blood is abrasive, like sandpaper. The intima of the artery adapts to this assault by forming a callus to protect itself from injury. At the same time, the blood flow dividers at arterial bifurcations are subjected to yet another type of injury. This is high shear stress, which occurs with every heartbeat, only at the peak of systole. These high-velocity bursts pound on the intimal surface of the flow divider, wearing it away. The intima adapts to this attack, forming its own type of callus to protect itself. Think of these calluses as the normal physiologic response of the intima to mechanical injury. Nature has programmed the epidermis and other cells in the body to protect themselves from repetitive injury in their own ways. The arterial system is no exception. These calluses eventually develop into what medical science calls early atherosclerotic plaque. Each callus, a bump in the arterial wall, further disturbs the blood flow and creates more turbulence in the non-compliant regions. This sets into motion the end stage of the deadly cycle of atherosclerosis. In a distortion of the original adaptive process, the callus grows as this cycle accelerates. The increasingly turbulent blood flow instigates the buildup of more and more plaque. How fast the plaque grows and what shape it takes depends on the composition of the blood, genetics, lifestyle, and environmental stresses. Most often, the final event is plaque rupture or dissection that almost instantly stops all blood flow. A stroke, heart attack, or amputation follows. The chain of events that force the heart to overwork and to function so inefficiently has again claimed another victim. One of the 60 million Americans afflicted with cardiovascular diseases.
This concludes our webinar. Thank you and have a great rest of your day.